Thank you, Ronaldo, and thanks for asking me to talk. And I have to thank Neil Glassford as well for inspiring this as well. My interest in this really started as I commenced doing some adult intensive care, having grown up in paediatrics. And I remember taking referrals from the emergency department of where, patients would be referred who have had tachycardia, fever, and we put an IV in and we gave 3 to 6 litres of fluid. And I was like, 6 litres of fluid? I have to come down and see this. I mean, that is the amount of fluid I give to some 200 neonates. And that's just an extraordinary amount of fluid. And for a paediatric intensivist, that was really where that started to spark some interest. So, and then when I arrived at the Austin, we talked more about this, and it got me to look at what we actually know about fluid bolus therapy in paediatrics, and particularly with respect to sepsis and severe sepsis and septic shock, which accounts for about 40% of childhood deaths worldwide. And as we know, just as in children, just as in adults, fluid bolus therapy is the mainstay of resuscitation. And our consensus guidelines recommend up to 60 ml per kilo of volume resuscitation, even up to 200 ml per kilo in the first hour. So just to give some perspective, I mean, for a 10-kilo, 1-year-old child, that's up to 600 ml, and that's quite an amount of fluid. And early goal-directed therapy is embedded in these guidelines. So specifically, the clinical practice parameters were originally devised in 2003 and updated again in 2007, mainly at the instigation of a fellow by the name of Joe Carcillo. This is the algorithm that currently stands. You can see that a fluid bolus is defined there as 20 ml per kilo and up to 60 ml per kilo. And once you've exhausted that, and interestingly, the targets there are clinical. And so essentially until perfusion improves or you develop severe fluid overload and pulmonary edema. And then embedded within that is the target, the haemodynamic target of a central venous saturation of greater than 70%. And again, this is endorsed by the Surviving Sepsis campaign, and also mentions a target of central venous saturation of 70% and a cardiac index of 3.3, which I must say it's not such a common thing to monitor that target in children. And so when you look back to see what really instigated this, what's the evidence base to support this, you come back to this pivotal study done in 1991, which was essentially a case control series of 34 children. And they had central venous catheters placed early within the 6 hours of sepsis, and they were subsequently divided into 3 groups. So the first group was those who received less than 20 ml per kilo per fluid bolus, and the second group 20 to 40, and the third group greater than 40 ml per kilo. And it's, in essence, this is what was found. 7 deaths in group 1. I'm sorry, that was 8 deaths. 7 deaths in group 2. And so that's really, this limited data is really what is the foundation, the basis of fluid bolus therapy in children for those guidelines. And so, but there are data in the underdeveloped countries, and specifically for certain conditions such as malaria, dengue fever, and also malnutrition. This is where the bulk of the studies have been thus far. But when you look at them in total, they're actually, not many of them actually compare fluid bolus with no fluid bolus. There's often different fluid types that are compared. And so in the few studies that in malaria that look at no bolus versus bolus therapy, there is no that no bolus show reduced mortality. And there's insufficient data really for dengue when it's all meta-analysed. And they really compare different types of fluid. Here are 2 African elephants, and one of them, thankfully only one of them's in this room, but probably of sufficient impact. And I must say, I'm impressed with how the adult intensive care community have taken on this trial to question their current practice. I think I'm the third presenter to show this slide where mortality was reduced in the arm that got no fluid bolus therapy. So 4% albumin, normal saline, or no fluid bolus for febrile children with reduced perfusion, and a significant difference in mortality, and again holding out to 4 weeks. And so the interpretation of this was that, look, this is specific populations, this is Africa, they didn't have markers of shock that are recognised by WHO, they didn't have intensive care capabilities, they had malaria, they had a haemoglobin of 5, maybe they had meningitis, maybe they had SIADH, we weren't monitoring sodium. However, it is the largest randomised controlled study in paediatrics. So we thought we'd look back and see what the evidence supporting this is, and early goal-directed therapy in paediatric sepsis and septic shock, where there are intensive care capabilities. And so we aimed to identify studies of this, and particularly studies where there was a difference in volume administered between the two groups. And we looked at the additional intensive care interventions and the patient-centred outcomes. And so we took studies where there was either a clinical or a haemodynamic goal-directed therapy, and the control group was any other type of goal-directed therapy or no goal-directed therapy. And they're the outcomes we looked at. So we specifically excluded neonatal studies and disease-specific studies, and any studies that didn't look at either a crystalloid or a colloid. These were the broad search terms that we used and applied a paediatric filter, and we identified lots of publications, and ultimately between a Medline search, an Embase and a central database of manuscripts, we identified 3 studies in the final analysis. And for non-randomised studies, we came across 8 studies. So let's just look at the randomised control study. The initial one is a multi-centre Brazilian study, which is the only one that used a hemodynamic target of central venous saturation of greater than 70%, and 102 children in that study with fluid refractory septic shock. The 2 other studies were both from India. They were single centre. They didn't quite use, they used different fluid protocols, and the latter study used normal saline versus a gelatin. And in essence, between those 3 studies, they all showed a difference in volume resuscitation in the first few hours, but they measured the timing of fluid therapy at different time intervals, so the blue there being those in the intervention and the red in the controls. With respect to intensive care interventions and outcomes, only the Oliveira study showed differences in the amount of inotrope used and blood transfusion, and it was also the only study to show a difference in mortality. At 28 days, 11.8% in the intervention and 39.2% in the control, with no impact on shock reversal, length of stay, mechanical ventilation. And the other 2 didn't show any significant outcomes. For the non-randomised studies, look, this was a really difficult collection of studies. They were retrospective, largely North American. There was 1 transport service, and they either compared survival or shock reversal versus no shock reversal, and a proportion of them also examined whether there was adherence to protocol. And this largely demonstrates that there was a difference so they all demonstrated a difference in fluid volume resuscitation, but between them, they were a very heterogeneous group of studies and different, whether you survived or not. Some had more fluid, some had less fluid. So, and again, a very biased population of studies. The 2 circled studies there show proportion of those achieving 60 ml per kilo in the first hour rather than total fluid volumes. And there wasn't much of a difference in the intensive care interventions, not that significant, but Oliveira was the only one that, Oliveira and Hahn demonstrated there was a mortality difference. So if you received less than 20 ml per kilo, you had a 73% mortality, and greater than 40 ml per kilo, 33% mortality, and that's actually quite high in both groups. And Hahn showed that in those that were shock reversed, they survived. Not shock reversed, they had high mortality. So Look, this was a broad search for the evidence base for fluid bolus therapy in paediatrics, sepsis and septic shock. And it was a general population, it was a critically ill population. We demonstrated that there are differences in fluid volume resuscitation, but really it was such a large heterogeneity amongst the studies that it was really difficult to meta-analyse and because of study design and their outcomes. So we've really only identified one study that showed a mortality difference using early goal-directed therapy, and yet this is what is embedded in our guidelines. There was a large mortality benefit in the control group, which doesn't really represent a normal practice. And interestingly, no randomised studies from North America or Europe, and what physiological data was reported, there was no difference between from time 0 to 6 hours, so very little physiological data as well. So in essence, there's very little supporting the ACCM PALS guidelines for fluid bolus therapy in this population. And I think, you know, we've seen a lot of data today showing the physiological effects, and I think in paediatrics we're at that cusp there. We're a little bit before, and we need to look further into this and document what happens with, from a physiological standpoint for children with sepsis and septic shock and what happens with fluid boluses. Thank you.